If you have that kind of chronic back pain that just seems to follow no rules, one day it's fine, the next it's awful, and it's triggered by the simplest little movements, then this explainer is definitely for you. We're going to break down one of the most misunderstood causes of back pain out there, lumbar instability. And we're going to start with the one question almost everyone asks.
Does this sound familiar? You're feeling okay, and then you bend over to tie your shoe, or you just get out of your car, and bam! The pain is just debilitating. Or maybe you get that terrifying feeling that your back is about to give out. Listen, that is not in your head. It's a classic sign that there's something mechanical going on.
The key to really understanding this type of pain is to kind of shift your whole way of thinking. This isn't just about a sore muscle or some general ache and pain. The issue is often with the structural integrity of your spine itself. The very architecture that's supposed to hold you upright is becoming, well, unreliable.
So what is lumbar instability exactly? Well, there's the clinical definition. But let's think of it this way. Your vertebrae are like a stack of blocks. They're held in place by four key things: the disc in the front, the ligaments, those little facet joints in the back, and of course, your muscles. Think of them like guy wires holding up a tent. If one wire starts to loosen, the others have to work overtime. Instability is what happens when those guy wires start to fail one after the other, and one block starts to slip and slide way too much on the one below it.
See how specific these triggers are? These are not random aches. Getting out of a car, getting up from a chair, climbing stairs. These are what we call transitional movements. They're moments where your body has to dynamically restabilize itself. When a part of your spine is unstable, it fails that test, and you feel it as that sharp, mechanical back pain. And if that slipping vertebra happens to pinch a nerve, well, that's when you get that lightning bolt of pain shooting down your leg.
All right. This brings us to what is for so many people the most frustrating part of this entire journey. You are in very real, significant pain, but you get an X-ray or an MRI, and the report comes back saying everything looks more or less normal for your age. It's this huge disconnect, and it can honestly make you feel like you're going crazy. But there is a very good reason for it. This right here is the heart of the problem. Even the experts admit that what they see on a standard scan doesn't always line up with what the patient is actually feeling. And this isn't some new debate. It's a well-known challenge in spine care. Your symptoms are real, even if the first-line imaging doesn't see the problem. So just how good are those standard tests? Well, the data on flexion-extension x-rays, the ones where they have you bend forward and backward, is frankly shocking. They only successfully identify lumbar instability between 6 and 19% of the time. Just let that sink in for a second. That means over 80% of people with this clear mechanical issue can be told their spine is stable based on the most common test used to find it. This is the imaging gap, and it's exactly why so many people suffer for years and years without a clear diagnosis. So why does this happen? Well, the reason is actually pretty simple. If it hurts to move, you're not going to move. You subconsciously limit how far you bend, which means the X-ray never gets a chance to capture the abnormal motion. The good news is there are better ways. Specialists can use different kinds of dynamic imaging or look for subtle clues on an MRI, like extra fluid in those small stabilizing facet joints, to really get the full picture. Now, it's really important to understand that instability isn't like an on-off switch. It's a process. It develops over time, a problem that exists on a spectrum. So let's take a look at the model that experts use to explain how this all happens. This is the famous Kirkcaldy-Willis cascade, and it's basically the life story of a spine segment over many decades. It starts with step 1, dysfunction. This is sometimes called micro-instability. The disc and joints are starting to wear out, but there isn't a big, obvious slip yet. Then it progresses to step 2, the full-blown instability phase. This is where that abnormal motion really kicks in, and you might get diagnosed with something like spondylolisthesis. Finally, the body tries to fix the problem itself in step 3, restabilization. It grows bone spurs to try and lock the segment down. The problem is, this can create a whole new issue, spinal stenosis, which is a narrowing of the canal that can end up pinching your nerves.
Okay, so we've defined the problem, we understand the frustrating diagnostic gap, and we know how it develops over time. The big question is, what do we do about it? Well, the path forward is actually very logical and stepwise. For pretty much everyone, this journey is going to start with conservative care. But, and this is a big but, when it comes to instability, not all physical therapy is the same.
Yeah, this isn't about going to the gym and doing 1,000 crunches.
Stability-focused PT is super specific. It targets those deep internal muscles, like the multifidus and transversus abdominis, that literally wrap around your spine like a natural corset. The goal isn't just about brute strength. It's about training these muscles to turn on at the right time, creating this muscular brace that helps make up for those loose ligaments and worn-out joints.
A lot of people find real significant relief with this kind of targeted physical therapy. But for some, the mechanical problem is just too far along, and the pain and limitations just don't go away. So when you've given conservative options a real shot, and they haven't worked, it's time to have a conversation about surgery.
Now, when it comes to surgery, there was a landmark study that really changed the whole conversation. It compared two main approaches. The first is decompression, which is where a surgeon just makes more room for a pinched nerve. It's mainly focused on relieving leg pain. The second is decompression plus fusion, where they do that, and they use hardware like screws and rods to permanently stop the unstable vertebrae from moving, which is focused on the mechanical back pain. But look at these 5-year results. The success rates and even the reoperation rates were basically identical.
So what's the big takeaway? It's this. The best surgical choice really depends on what your main symptom is. If your biggest problem is leg pain from that pinched nerve, decompression alone might be all you need. But if your life is being ruined by the mechanical back pain from the instability itself, then a fusion to stop that motion becomes the much more logical goal. And with modern, minimally invasive techniques using robotic assistance, the results can be fantastic. Studies show 80% of patients are doing better within just 3 months and can be back to work in about 20 days.
Okay, let's bring all this home. If this story sounds like your story, the unpredictable pain, the normal scans, the frustrating journey, you are now armed with the information you need to have a totally different kind of conversation with your doctor.
Here are the 3 critical questions to bring with you. Number 1. Has anyone confirmed the specific unstable segment with hands-on clinical tests, not just by looking at a normal MRI? Number 2, if my standard X-rays were normal, have we considered ordering the kind of dynamic imaging that can actually see the instability? And number 3, can you give me a clear, structural explanation for why my symptoms are so unpredictable? If the answers you get are no, then your evaluation probably isn't complete, and seeking out a spine specialist team like Dr. Kamal Woods at Vertrae in Dayton, Ohio is a great way to finally get those answers. You can find more information at vertrae.com.